And it is now my pleasure to introduce our speaker for tonight. You guys probably already know him. He's been on several Woo U events, highly requested speaker. Dr. Greg Caldwell is a 1995 graduate of the Pennsylvania College of Optometry. He completed a one-year residency in primary care and ocular disease at the Eye Institute of Philadelphia, Pennsylvania. He is a fellow of the American Academy of Optometry, and he's also board certified by the American Board of Optometry. On top of working with Enhanced Eye Care as an ocular disease consultant, he is a well-respected lecturer. He's lectured several times in over 12 countries, and he's given over 300 lectures in numerous cities in the United States. He's also participated in multiple FDA investigations, and he is a true expert when it comes to nutrition, anything related to the back of the eye. I mean, Greg really knows it all. So, Greg, it is a pleasure to have you back.
Dr. Wu, thank you very much. It's very kind. So here are my disclosures, and what we can say is all the financial relations have been mitigated here. We're going to be doing ocular nutrition, tying structure, function, and molecular all together. But, I have to thank, Dr. Wu and her team. We have Maureen, we have Helen, we got Jenna behind the scenes here tonight. And really, to be able to pull this all off, we can't do it without a great, staff. And thank you all for being here. So let's jump into it. Again, we already covered this, but you can see this whole laundry list of companies. And how does a guy from Duncansville, Pennsylvania get the privilege to be able to speak to colleagues? And it's really kind of hanging out with the companies and kind of knowing what's coming. So I don't really put this up here to really impress everyone or anyone that's out there. It's really to be able to deliver high quality education so we all can be better in patient care tomorrow. And they all have been mitigated. We can't really do a nutritional lecture without, thanking Dr. Stuart Richer. I'm not sure if you guys and gals are aware, but Dr. Richer did pass away last October. So please keep him and his family in your thoughts and prayers that are out there. So really, we're going to jump off real quick with a polling question. Let's see if I can get this launched. If Jenna, if I can't, I'm just going to ask, the polling question, where is the macula? Is the macula the orange or is it the blue? Is it the orange? Is this the macula? Or is this the macula? Blue or orange? Just going to start off really quick here. Remember, this is interactive, synchronous type of learning. So we're making it interactive. We're making it synchronous. And I see lots of people rolling in with an answer here. Orange or blue? It's confusing at times, I think. Orange, blue. All right, lost the poll. I got someone rolling in here in the chat box saying blue. Nothing's in the question and answer. All right. We have a pretty good response here. So what I'm going to do is just end the poll. We got the trend. I'm going to share the results. And you can see here that the majority is saying blue. And we've got 42% saying orange. Let me stop sharing. And let's see if I can go back. And I'll be ready to get ready to the next poll. The answer here, we can show it a little bit later here, is the answer is blue. The macula is 2 disc diameters from the fovea or from the foveola. So you can go 1, 2, 1, 2. So what we were pointing out here is the fovea, and you're going to see here that when I talk tonight, I'm going to be talking and focusing on a lot of the lutein and zeaxanthin because that's where optometry has cut its teeth. Now you're going to see I'm not a lutein. I'm going to say it right now. I'm not a lutein and zeaxanthin hater. They are found in the fovea. They are super important. The fovea is the third lens of the eye. We have the cornea, we have the lens. It's curved to the fovea, and it's got lutein and zeaxanthin in it to act as a no glare. It does help with making glare disability, and it cuts back on the blue light. So it helps us with our contrast sensitivity. Now, as you'll see when I go through some slides, that it does have macular degeneration protection. But, this retina is brain. It needs to have a lot more than lutein and zeaxanthin. And really, if this is the macula right here, as we're trying to show, we have to take care of the rest of the retina, right? If we're just focusing on the macular pigment, what about the rest of the retina? So that's really where this lecture kind of spawned from. So, there's some doctors out there, this Lisa Renza Hammond. She has spent her life, in a sense, studying the macular pigments, right? Lutein and zeaxanthin. I listened to a great 1-hour lecture from her. I'm going to go through 2 people and paraphrase from their lecture. She says, the retina is one of the most metabolically active tissues. And I agree with that. That's why we need to do more than lutein and zeaxanthin. It's the canary in the coal mine. That's why we see a lot of end organ diseases there, diabetes and all the different diseases that we're well aware of that can affect the eye. It's an end organ, just like the heart or the liver. It can get damaged. We see a lot of 300 diseases can be detected in an eye exam. The retina has more than one blood supply, so it's metabolically active. The retina is brain, most blood supply than any other part of the brain. So it's very prognostic that's out there. So she mentions that, the macular pigment is anterior to the photoreceptors. I want to stress that as we go through tonight. And the disease of macular degeneration is down at the RPE level. And we're going to talk about where we see these genetic mutations. Again, she talked about from an evolutionary standpoint, the macular pigment really wasn't put there for macular degeneration, although it does help, again, glare disability and photostress recovery. And in the United States, we get most of our lutein and zeaxanthin from baked goods, corn, and eggs. She mentioned that we don't need to have these mega doses and discuss diet and food with your patients. You don't have to be a nutritionist, and I agree with that 100%. Then there was a lecture I listened to, Dr. Paul Bernstein. He's an MD, spent his whole life kind of researching these macular pigments and actually finding the binding proteins. And he writes, in his lecture, he pulled out a few things. I pulled out a few things. It says, many nutrients are very important to the eye. He started with vitamin A research and moved into lutein and zeaxanthin. And he mentioned that, nutritional intervention is, potentially better than pharmacy because compliance can be higher. The patient and the practitioner have a high interest, and it could be a much more cost effective than the medicine that is needed later, or surgery, or the disease process. And just a reminder, he went through that there's clinical observation, biochemistry, and physio. There's animal and human trials. We as allopathic doctors love to see human trials. I'll show you some of my clinical observations and what we would call epidemiological tonight with some cases. He mentioned that, the macular pigment is very focal and found in a very small spot. And he found these binding proteins. You're going to see why, these binding proteins are going to need some cofactors to help them to be in the area to allow the lutein and zeaxanthin to bind. The eye is designed to take on light. It's under a lot of oxidative stress. Lutein and zeaxanthin, are strong blue light absorbers. The peak is 540. That's why it cuts back on that glare, helps with that, the photo stress recovery. But the rest of the retina, it needs that whole A to Z type of approach, that whole comprehensive antioxidant network. This is, again, he was showing right here from a historical concept, right? Here is the macular pigments. And remember, we pointed out that the macula was pretty big. You can see that they kind of just hang out here in the layer of Henle, anterior to those cones and, the rods. And again, they're super, super important. But look how limited we are, when someone comes in and we say, hey, Dad has 53 injections in their eye. What can I do? I go for a more comprehensive oxidative approach that's out there to kind of give that whole retina and that RPE And remember, this is the macula size right here, and we can see that this is where these macular pigments are building up. So he pointed out, there's many ways to measure macular pigment. We can do, oops, I have this spelled wrong here, high performance liquid chromatography. So I have to correct that there. So that's what HPLC is. I see psychophysical, if you guys have done MPODs. And you see he'll mention that when you do studies, it's good to do autofluorescence, reflectance, and Raman spectroscopy. And he has this right here on his slide. You'll see here as I go through some recent studies that he's doing. He has the original hand scanner in his lab, and he pretty much uses all three of these. Now, you don't have to be a scientist, and what I don't need to have all these instruments in, I just need to know whether their measurement is high or low so that I can intervene properly. So here we are with, again, the different levels of the hand scanner. All right, so basically here it is here, the S3 version. All right, so anytime I see Paul Bernstein on anything, I pretty much read it. The gentleman is constantly doing studies, devoted his whole life. So this came across in ARVO, May 2016, where he basically says, our emphasis and the importance of measuring the amount of carotenoids in the macula using objective. I'm going to go back a slide. See, we're using these imaged base. That's where he wants to be, image based. Now, he's a scientist, so he likes to know in autofluorescence how much lutein and zeaxanthin there are. Now, you could see here that I highlighted in the same conclusion, skin resonance Raman spectroscopy, skin carotenoids are a reasonable biomarker of the macular carotenoids. So he said that, and there's been plenty of studies out there to say what we do in the hand is what happens in the blood, and that's enough. But if we're trying to say, okay, what's happening in the macula, you can then correlate to that. And he's saying it's better than the MPOD. And you can see here is the hand scanner telling you what's in the blood. Correlation studies have been done telling what's in the macular pigment and been studied many, many times. he just completed this study, the lutein zeaxanthin pregnancy study. And you can see here he's using the different types of measuring, reflectance and autofluorescence. Here's the original hand scanner. This is a hand coming in right here. We can call this the S0. And really, you can bring in scientific laboratory type of testing right into your office by doing this. So a lot of people are like, oh, has this been used in studies? The cool thing about the scanner was it was developed by the National Institutes of Health. It wasn't with the pharmaceutical company that it is. It eventually, the patents got taken over by the company, and that's how it got tied to the PharmaNex company. So this is really cool. He's doing the Moran. That's where he practices Moran, the AMD genetic testing assessment study. It's called the Magenta study. That's why this is all underlined. This is now funded, and again, using the different ways to measure. And again, he's going to use Raman spectroscopy in his study, which is really, really cool. Because people always say, how accurate is this? Or, can you show me a study? Well, I can show you a study, and I can show you studies where it's being used in the studies. So really, really cool using Raman spectroscopy that's out there. So again, you can have something that's being used in studies right there in your office. All right, so I'm kind of curious here. You can use the chat box. I'm going to move a few things around because I'm going to kind of watch what happens over time. I'm not going to wait for this. So the answers that you could put into the chat box, and I'll see as the lecture goes on, there's going to be an AREDS 3. And if you wanted an AREDS 3 and you were putting together AREDS 3, what would you put in that formula? Would it be fatty acids? Would it be resveratrol? Would you put lutein and, the other things other than vitamin C, E, lutein, zeaxanthin, and copper? And here's what I find out that's kind of funny, right? Someone already put in, and I believe that the people in the audience can't see the answers going into the chat. Fatty acids first, omegas. I have all these omegas rolling in right now. Keep putting in what you think. But look what AREDS 2 study said. There is no benefit from fatty acids, right? So sometimes, the studies, in a sense, can be wrong. We all know now in 2023, omega-3s, DHA, EPA are shown to be protective. The AREDS 2 study said they were not protective. So kind of curious as it goes on. Let me just see as you guys go. It says all the above. I see some answers, AREDS 2 plus omega. What else do you think? And as we go through here, maybe you'll see some of the things that I feel that will end up or should end up in there. All right, Greg's comments. I think the macular pigment is misnamed. I think it should be called foveal pigment. It's really condensed down. Those binding proteins that we talked about need coenzymes and cofactors. We mentioned this earlier. The macula is the third lens of the eye. Lutein and zeaxanthin are important for vision and focusing and contrast. I'm not taking it away. It should be in the formula that you're using, but the formula needs to be comprehensive. Many people talk nutrition, few are measuring it. And if doctors don't become more like nutritionists, the nutritionists are going to become more like doctors. And you know what? You can't supplement someone out of a poor diet. It also needs to change the food that's out there also. Short wavelength filter is embedded in pre-photoreceptor position, the layer of Henle, again, blocking that blue light that's out there. All right, let's jump into more. Why are we talking about this? Patients are expecting early detection, wellness, and prevention. Patients are expecting that now. And I can tell you, I've walked through a lot of exhibit halls. I've been to a lot of meetings. I have this in my office. I've been playing around with it, the Rabin cone contrast test. I'm doing genetic testing. I have dark adaptation. Thinking about bringing this in, the ReadyVal, doing ERG VEP. Here's what's happening, and this is why I think it's important for us to focus on these lifestyle changes, exercise, sleeping, recovery, meditation, and nutrition, is that we're moving early diagnosis up so close that we really don't have an opposites or allopathic cure, right? When I went to school and I graduated in 1995, did my residency in 1996, I was still diagnosing glaucoma by a stereo disc photo, looking at the neuroretinal rim and visual fields. GDX wasn't out. OCT, ganglion cell, nerve fiber layer. Now we have these functional tests like ERG, VEP, and cone contrast testing that are now functional tests. We had function, visual field, structure, OCT. Now we're getting back to functional testing, testing the individual neurons. How are they firing? Testing the cone contrast test. We're getting so early, we better understand nutrition because we might not have a pill for that ill that's out there. So here's what's happening. This is the cell membrane. You're going to hear me reference, omega-3s and the cell membrane tonight. So we know that omega-3s and omega-6s, they're essential. That means we have to take them in. Our body can't produce them. Omega-3s come from fish. So we have to eat our fish. There's some other plant supplements, but when you talk to the nutritionists out there, they truly believe that we should be getting them from fish. And what that does is that it's that, here we go with this picture. This is the phospholipid bilayer membrane. Phospholipid, meaning fat. So we have fat here. So this is where the omega-3s, the omega-6s, the omega-9s, making that cell membrane ready for all these potassium channel pumps and these gatekeepers. This cell membrane needs to be super, super healthy. And that's ready to take on those fat soluble. I think most people know that vitamin E is fat soluble. If the cell membrane is not flexible and pliable, it really can't take on vitamin E. Vitamin C is water soluble. So it goes to the interstitial space and it goes to the inside of the cell and it does its nourishment as it's supposed to do. Let me show you what a properly oxidized cell membrane interstitial space and inside the cell looks like. This is what we want it to look like. So this is where the scanner comes into play. When someone comes in and they scan low, this is what their cell membrane looks like. These free radicals, which are basically missing an electron, need to be balanced. And if they're not balanced, they'll get that electron from somewhere. We don't want it from things inside the cell, like the DNA or the nucleus or the endoplasmic reticulum or the cell membrane or the channels, right? The reason why we were scavengers and why we were supposed to eat all these fruits, vegetables, and nuts was to allow our cell membranes to look like this. Bring on the free radicals. This is the way we're supposed to look. And we'll go through and I'll show you that the score, when you score low, look like that. Not good, setting us self up for chronic disease. And that's where we're not the best in America. We're great at acute disease, heart attacks and strokes and so on and so forth. We're not great at really prevention, so on and so forth. The world doesn't come to us. But guess what? Lectures like this and a little bit of attention, we're getting better in the United States at it. This is how we want our cell membranes to look. All right, comprehensive oxidative support. Plenty of literature out there showing that it supports that cell membrane. It's immune, right? COVID taught us that. Support to the oxidative stress and support to reduce oxidative stress and that extracellular matrix, like I just showed you on that slide. And the cells do talk to each other. So that's what we call cell signaling. All right, Jenna, I'm going to let you shine with this one. I'm going to let you run poll question number 2. Is there, do you consider yourself an integrative medical optometrist? So polling question number 2, do you consider yourself an integrative medical optometrist? Yes, no, or, doc, what the heck are you talking about? All right, let me go look at the chat here. So this is pretty cool, right? Remember, AREDS 2 said, It doesn't help. Everyone wants omegas in there, omega-6, omega-3s, astaxanthin, that's pretty cool. Resveratrol, that's pretty cool. Turmeric, right? I agree. We have more omegas, zinc oxide, beta carotene. Yeah, let's put beta carotene back in just at the lower dose, right? Beta carotene still good. Mesozeaxanthin, vitamin B, right? Agree. Vitamin B, resveratrol. When someone put vitamin C. All right. I think we got a pretty good, we got about 51% people rolling in here. Jenna, you want to end it and share those results? I think we got the trend, and we can see here that 46% say yes, 22% say no, and 33% say, what the heck are you talking about, Doc? What the integrative optometrist? All right. So who here would consider themselves an integrative optometrist? That was the polling question. Well, let me just say, if you've done supplements, if you've done AREDs, omega-3s, EPA, DHA, if you have any of those fish oil supplements, Vital Tears, ACED, tea tree oil, Clearadex, hypochlorous acid, Regenerize, amniotic membranes. If you've done any of that, you're an integrative optometrist, because none of that is opposites cure. Allopathic medicine is, hey, you got a sty, give them an antibiotic. You got inflammation and iritis, give them a steroid. Functional medicine or naturopathic medicine is using natural things. Vital Tears, you're taking, serum out of it, spinning it and turning it into eye drops. Fatty acids, supplements, amniotic membranes, can't get any more natural than that. The amnion of a placenta, there's nothing there that's opposite. You're using the biologics. So if you have done any of this, I would bet the ones that are the 33%, I would say that you're now an integrative optometrist. And if you, of those 98 that said no, if you did this, now you're an integrative optometrist, didn't really know. Again, allopathic is opposites cure. And what we're doing is with these treatments is when we're especially talking supplements, we're taking things that are naturopathic or natural there, but complementary or integrative medicine is taking these chiropractic, Chinese medicine, supplements, taking these things found in nature that we know that are positive and can help, and integrating them into our allopathic background. So I bet you a lot of you thought that you were doing opposites cure, but you weren't. You were actually doing, maybe a naturopathic type of approach, a homeopathic type approach, and now you're integrating it into your schooling that was mainly allopathic back in the day. Taking that Western medicine and integrating it into your current allopathic background. Now let's take a little jump here. So chronic and low-grade inflammation. Science has proven that chronic low-grade inflammation can turn into that silent killer. And it could be anything: cardiovascular disease, cancer, type 2 diabetes, and then we get to the eye, it could be cataracts, macular degeneration, glaucoma. And you could see here life expectancy versus health expenditures. United States is way over here, and the rest of the world is sitting over here, that the life expectancy is higher and the cost expenditure is a lot lower. And we just went through with this with my father, who passed away last October. A lot of the healthcare costs were over here for his last remaining, years. So we see this all the time in the United States. Chronic low-grade inflammation, like cancers and slow burn diseases, you can identify these conditions early. You can make a full recovery, or you can make a dramatic improvement to help their quality of life, or even death. Now, I just added vision loss or blindness. So we can see here inflammation, Alzheimer's, cardiovascular, cancer, pulmonary disease, and then all the ocular diseases that we know that are tied to that. So polling question number 3 out there for us, Jenna, is we hear choose your parents wisely, right? Our genetic background, you want to have good genes. So what part of our genetics cannot be influenced by our lifestyle choices? Okay, so we'll get that polling question up. Thank you very much. So we have our genes. So in other words, I have blue eyes, I have black hair. It's getting a little gray in there, but I have blue eyes, black hair. I really can't change that via maybe what I'm eating, my lifestyle changes. I can't exercise myself out of black hair. So there's certain percent of our genes that we can't really change, but what we do to ourselves, you're going to hear me say exercise, stress your body, let it recover, in nutrition. There's a certain percentage out there that what we do to ourselves, so what can we not change? Is it 100%? Because that's our genes. We can't change or the outcomes of our lifestyles. What part of our genetics cannot be influenced by our lifestyle? Is that 100? Is that 80 to 90? Is that 48 to 50? Is that 8 to 10 or 0? All right. Yep, Raymond, you are an integrative medical doctor. You have a new title. I can deem it to you. All right, let's end that poll. We got a nice reply. Thanks, Jenna. Appreciate you on the background there doing that. And you can see the results. A few people say 100%. We got 80 to 90%. Most of you feel 50%. Here, let me show you. 8%, depending on what study you read that's out there and what functional medicine and who you listen to. But it's 8, it's 10, it's 12, depends what you read. But 8% of what is in your body you cannot change. That's what makes my hair black. That's what makes my eyes blue. But they feel 92% of what you do, lifestyle, again, exercise, recovery, sleep, yoga, deep breathing, meditation, and then nutrition is what turns out to be 92% of some of the outcomes of our body, allowing those genes to express that's out there. So when it comes to biomarkers, there's a biomarker is a visual acuity. That's a good one. An IOP, that's a biomarker. Heart rate, genetic testing, blood pressure, and blood work. But if you ever been to a functional medicine doc, they have their top 8, their top 10, their top 20, whatever it is, predictive biomarkers. I think we'd all agree that hemoglobin A1C is probably a better predictive biomarker than blood sugar that's out there. So you're starting to see maybe time in range with all these glucose monitors, that might replace it. But right now, if you go see a functional medicine doc, they're probably going to do a hemoglobin A1C. They want to see if maybe there's some insulin resistance. They'll check C-reactive protein and homocysteine. They want to see the inflammation. Vitamin D, that's even done by the primary care docs. Now, let me point out, vitamin D is the only hormone that I'm aware of that is produced by anything other than a gland. It's produced by our skin, right? The largest organ in our body, our skin. You have the cholesterol, the UV, it goes to the liver, the kidney, I forget which one first, kidneys, then liver, then kidney, and gets converted and eventually into vitamin D. And then vitamin D works as a hormone. Omega-3 index, and look what some of the functional medicine docs put on there, carotenoid levels. Carotenoid levels are important, but I'm going to show you how that biomarker, in a sense, can be misused. So a biomarker of carotenoids is important that's out there. So polling question number 4, we're going to start to drive this home a little bit. When you measure macular pigment, you can do that through an MPOD, or you measure carotenoid levels, say through the skin. You could do it through the blood, but most of us are not ordering blood work for, and then reviewing it. And that's what the hand scanners out there will allow us to do. The hand scan of the carotenoid levels. Do you feel when you have this that the patient is, so they have low carotenoid levels? And Jen, I'm not sure if you can launch that polling question number 4. Thank you very much. So the question is, when you have that low macular pigment, or if you have low carotenoid score, the patient just happens to be low in carotenoids and the rest of the antioxidant network is normal, or they have low carotenoids and the rest of the antioxidant network is low. Which one is that? When you're measuring, whether it's through the Raman spectroscopy, you could say blood, or you're doing an MPOD, and you're measuring that macular pigment. Do you think that they're just low in carotenoids and that everything else is perfect? Or do you think that they're low in carotenoids and the rest of the antioxidant network is low? Guys and gals out there doing well. This is live and interactive, synchronous. Polling questions help make that happen. So, all right, Jen, I think we got a good mix, good percentage of people. And you can see here, and I agree, and so do 87%. That the measurement, right? The measurement when taken, whether it's an MPOD and you're low in macular pigment, the studies have shown through blood work that your whole antioxidant network is low. So that's why I, after taking some functional medicine, and you'll see some of the conferences that I attend, I like to go and replace the foundation with a full antioxidant support system, or what I call antioxidant replenishment therapy that's out there. So, I go to some of these courses and you hear hormone replacement and plasma-rich protein, PRP. I think what we as optometrists in this kind of functional space is we can be a part of this overall body antioxidant, but focusing on the eye with all the conditions of cataracts and glaucoma, diabetes, the cardiovascular diseases that affect the eye, macular degeneration, and reduce that whole oxidative stress on the eye. And hey, by dumb luck, it just happens to carry over to the rest of the body. Wow, what a great thing that we can do. Here's one of my favorite speakers. His name is Tanner Gibb. This gentleman, I would never want to play Trivial Pursuit of any nutraceutical with him. He's amazing. I went up to him and mentioned one time something. He goes, "Wow, did you realize there were 8 of those tocopherols out there, Greg?" I'm like, "No, Tanner, I did not. Thank you." But you could see here where they use things like in studies, low serum selenium and total carotenoid. Measuring those two together can predict mortality. Low level plasma carotenoids are independent predictors of mortality. The relationship between plasma carotenoids and the depressive symptoms, and also using, serum antioxidants are associated with the metabolic syndrome. Oh, okay, geez, how coincidental, right? Carotenoids as protective against disability in older patients, and the list goes on. So the key here is the measurement, because it's kind of easy to do through blood and through these skin measurements. The key is you're using that measurement, then talking to the patient and saying, "Hey, look, let's talk about your nutrition. Let's talk about your antioxidant network. And maybe let's get in here and start helping out with a comprehensive approach." Once you got the foundation, I don't have a problem at all if you want to go in there and supplement, let's say, with a lutein and zeaxanthin product. I have them in my office. I do it. But I like the foundation first to be strong before I go in and target that's out there. And you probably see a lot of your functional medicine docs trying to go that way. So the art of biohacking is the art and science of changing the environment around you, inside you, so you have more control. So basically it's taking these Oura rings, and I wear a continuous glucose monitor. I am not diabetic, not that there's anything wrong with it, but I like to see what certain foods will do to my body. And that's biohacking, so I can stay away from it. It's kind of funny. A banana that is yellow doesn't really do anything to my sugar. As it turns, it gets a little closer to being brown. Man, will that spike my sugar. And it's really kind of cool just how a banana just getting closer to maybe before you throw it away, before, I don't want to say rotten, but it's starting to become closer to that, how that starts to become more of a sugar bomb. Pretty neat. And that's what it does to my body. Doesn't mean that's what's going to do to your body. All right. So the annual reviews of nutrition. This is a pretty cool magazine. And you can see right here, it says ocular carotenoid status. And because carotenoids appear to play a key role in retina disease, maybe they should become an integral part of the comprehensive ophthalmological care. And it goes down through here saying that there's different ways of measuring it, but Raman resin spectroscopy of the skin is certainly a way to do it. And there's other ways out there that if you want to do it. Now, here's the hand scanner. And I see these at shows. And, here's the difference. If I said your blood pressure is 200 over 120, we know that that's a problem. If I said your blood sugar is 600, we know that that's a problem. I see people at, the shows, they're like, oh, mine scores 26,000. Don't worry about that. Mine's 19. I'll be dead tomorrow. No, that's not what we're talking about. We're not saying that this is going to kill you overnight, but the key is we know that this low score means that there's inflammation, and spin that roulette wheel. Where's it going to be? Is it going to be, from the head down? Is it going to be Alzheimer's or dementia? Is it going to be some type of cardiovascular, kidney, cancer, pulmonary disease, neurological disease, autoimmune? Go to the eye. Is it going to be some type of cataract, some type of macular degeneration, retinal vascular disease, some type of optic neuropathy, some type of dry eye, or glaucoma? The trabecular meshwork becomes very sticky. It becomes oxidized. I truly believe my patients, through the science that I have seen, need to be. So I see these, and, it kind of concerns me when our colleagues are like, mine's lower. I don't exhale till my patients get to 40. And really the science shows you should be in the blue to really start putting that body into a protection. This is generally where I scan, is in about 58 to about 54 or 64. This was a good day for me, or good, I was doing my smoothies and my exercise and keeping my supplementation going, wasn't traveling, wasn't on the road, was getting good sleep. I hit up to about 64. Right now, with all the traveling, I've been dropped down about 58. But this is about where I scan with this. And I like to do that because I try to practice what I preach about reducing this chronic and keeping this low-grade inflammation. So DNA, we talk about genomics as all of our genes. Genetics are individual genes. And epigenetics is the study of how our cells control gene activity without changing the DNA, basically internal and external environments. Again, the pollution that we're exposed to and the amount of exercise and the nutrition that we give our body, that's your epigenetics. You're going to see me reference this conference called A4M, the American Academy of Anti-Aging. Those are the 4 M's, the American Academy of Anti-Aging Medicine. That's the M. A group of MDs, DOs, pharmacists, nurse practitioners, optometrists now. It's been around for 30 years. And I learned this word there, exposome, the measure of all exposures of the individual in a lifetime and how those exposures relate to health. Okay, so I'm going to shift now. Remember, tying structure and function together, right? This is now going to genetics. We as optometrists can do this. This is a test that I have in the office, Visible Genomics. I haven't spoken for them, haven't received an honorarium, so I don't really have to disclose anything. But you can see here, looking at the SNPs, the risk alleles, and I want to point out, see complement factor H, complement factor 3, and ARMS. Right? So that's important. Now, why is that important? Because a lot of this stuff, and I believe Dr. Wu a few months back had me do this talk on immunology. We know we have an innate immune system. COVID taught us about our adaptive immune system. And this is a great little video series if you want to go to YouTube, Ninja Nerd. This guy is amazing. He teaches all the medical students to help them pass their boards. He gets this whiteboard out and starts drawing about, here's interleukin 8, and interleukin 8 does this to the cell membrane, and it causes these different things to happen. And you got your macrophage now. And so this is your innate immune system, your adaptive. Your adaptive immune system, T cells, B cells, forming those interferons, forming those antibodies, right, that get produced from those plasma cells. Whenever that novel coronavirus came in, our body adapted to it. What I want to point out is right here, he talks about the complement system. Remember, the complement system is a part of our immune system, that membrane attack complex. Now, I didn't add a slide in here, but Apellis just got approved for geographic atrophy. If you haven't heard about it yet, it's a complement factor 3, right? It's part of the immune, it's part of this genetic system. Complement factor genetic allele that has gone awry. Well, why? Because it's part of this complement factor. See this complement factor 3? When you see drusen in the back of the eye, down at the level, again, of the RPE, Brooks membrane, it's an immune reaction. That's why they came out with a complement factor 3 inhibitor. There's going to be a complement factor 5 inhibitor. My point is, you need to know the immune system. This is a great 8-part series. Go listen to it. It will take you a day or two. If you do it a little bit at a time, it will teach you about the immune system, but will help you all across optometry when it comes to these things. Now, what I want to point out here is, here's complement factor H in macular degeneration. They're trying to show you the complement factor H. Here's complement factor 3. Here's complement factor 5. Here is the RPE. Here is Brooks membrane. Here's your choriocapillaris. Do you see where this immune reaction is going on? This is why I am big on treating the outer part of the retina. You need to have some type of, if you're going to go with it, antioxidant that is found at the level down here. They have done studies. There might be trace amount of lutein and zeaxanthin. But your other supplements that we're going to talk about, why it's important, that OH group, your resveratrol, your curcumin, your astaxanthin, all these things that I've seen people that we're putting into the chat box are down here at the RPE level. That's why Stuart Richer was huge about resveratrol. Lots of resveratrol out here in the outer retina. Look where your genetic SNP is, and look where the disease is. RPE, Brooks membrane, choriocapillaris. Look where your Apellis is targeting down here in this level. C5 is going to be down here at this level. So what is the basis for the concentration of zinc, right? So this is where we talk about the controversy, right? 80 milligrams of zinc, 25 milligrams of zinc. In AREDS, there's 80 milligrams. So it comes through and it says some experts recommend low dose. The investigators did not find a difference between 80 and 25. Now, where's this controversy that's out there? The controversy is in about 2015 and 2016, studies were coming out, and it was saying that if you had no arms as a high risk factor and 2 in the complement factor H, taking high levels of zinc can promote choroidal neovascular membrane. Okay, I've got that out there. 80 milligrams. If you had a genetic profile, right? Let's go way back. A genetic profile of no arms, being low risk, and 2 being high, taking it could be promoting choroidal neovascular membrane. And you can talk to Jerry Sherman. He has seen lawsuits where someone had wet in one eye. They didn't change the 80 milligrams and someone didn't get genetic tested. And someone found this on the internet and they lost the lawsuit because they stayed on that 80 milligrams that's out there. That's the controversy, right? So here it is. But then the American Academy of Ophthalmology comes out and says, well, using complement factor H in arms does not predict that response. Controversy. When there's controversy, there's probably truth in between that's out there. A lot of the people that were on this 80 milligrams, this AREDS 2, when you look at the people that were on here, they were also in that AREDS 2 study that was out there that brought that formula to market. So you make your decision. Here's what I'm talking about. Here's polling question number 5. If you can launch that, Jenna. This is a previous front desk person at our office. Her mother has a family history of macular degeneration. So with that being said, we did some genetic testing on her. She has low risk arms, right there it is, low risk arms, high risk, low risk, high risk. Would you, if you can launch that poll for me, Jenna, the polling question number 5, would you recommend, if this was your patient, you did genetic testing on there, and she had intermediate drusen in her retina, which is what AREDS 2 is for, would you recommend AREDS 2, knowing that there are some studies out there, yes or no? Would you take the risk of promoting a choroidal neovascular membrane? Oh, it's a tight race here. It's a tight race. All right. If you can end that poll, we've got you can share those results and you can see, look at this. It's a tight race. We got 51 that say yes, 49 that say no. I could tell you that these studies have changed the way I practice. I don't like doing high dose zinc really in any stage of macular degeneration. You got the studies there, lots of the smart people out there. Because remember, not only do we get zinc from the supplement, a lot of bread has zinc, we get zinc from our diets. And, it's just like anything that's out there. Like we talked about beta carotene. When beta carotene was in the AREDS 1 formula, it was found to be toxic. Well, beta carotene can be like that, just kind of like Plaquenil. Given at too high of a dose, causes maculopathy. Given at the right dose, it helps people with rheumatoid arthritis. Drink some Fireball, drink a shot, you're going to be okay. Drink half a bottle, you're probably going to be sick. So the key is when you give things in high doses, sometimes that's not good. So I've ratcheted back. You guys, I present you the information. You decide what you want to do out there. If this genetic profile comes in, I did not do a high dose zinc with this previous front desk person at our office. So I see Raymond here asked about, what's your thoughts on Longevinex? Dr. Stuart Richard claimed, it could allow some AMD reversal. Yeah, it was really, really high in resveratrol. And I believe that, he was on to something. We used to chat a lot about maybe it needed to be more comprehensive. And that's a great question because here's things that I've been able to do in the practice. It doesn't happen to everyone. Again, let me repeat that. It doesn't happen to everyone. It's probably some immune reaction. It's probably some genetic risk allele. We've got some people that are more motivated than others, but I'm starting to see drusen like this. This is April 27 to 21, and 9 months later, here's the RPE scar. There's the RPE scar. This is before, this is after. This is that immune reaction that's down here, that complement factor. That's the difference between a soft drusen and a large drusen. A soft drusen kind of tight. What's the white fluffy stuff around it? The complement factor. Why is it white? What is complement factor? White immune reaction, right? That's the membrane attack complex. So what we were able to do is help take away some of that immune reaction going on down here with this patient. Here's another one. How about this patient here? You can see I'm really meticulous about making sure we get, here are drusen, 1, 2, 3, and some out here. You can still see have some drusen, but you can turn around this and it's in the outer retina. And then this one here, right? I still hear my colleagues out there lecturing, a lot of smart guys in retina, but they'll say, this is controversial, right? This is not. I was able to start to reverse these drusen. I'm going to show you why it's not controversial. Remember this as it comes forward. This would be considered maybe mild AMD. Let's talk about that in a little bit. Remember this picture, and these drusen 1, 2, 3 starting to become a little bit fuzzy down here, before and after. All right. So with that being said, We have oxidative stress. This is from my A4M conference that I love going to. It's in Vegas every year. It's in December. I'm going to the one that I've never been to it. This one, it's in Orlando in May. I'm looking for it. It's a much smaller group, but it's this right here. This is James Lavelle. And I just took a screenshot of his presentation. I took a picture while I was in there, giving him the kudos of this slide. And you could see it says oxidative stress inflammation. This is what the kind of the anti-aging and vitality, it says right here, the tenets of aging and performance and vitality. Reduce that oxidative stress, reduce the inflammation. It's usually at the top of every anti-aging and vitality. And watch those hormones and stress hormones. Make sure you're not insulin resistant. Work on that gut. Get that immune system kind of not firing on its own self. The environmental exposures that are out there. And remember, everyone's an individual. You can't treat people with broad brushes that are out there. That's why we have to measure and treat people. So ask yourself, I love doing this when I do a live audience, ask yourself, here's the RPE, the arrow's coming down here to this white line. Ask yourself what you call that on an OCT, right? We call that it's changed over the years. It was the inner and outer segment of the photoreceptors, the IOS, the OS junction. Then it changed to the photoreceptor integrity line. We now call it the ellipsoid zone. What I want you to do is really focus as I go across with my arrow here. Look how bright and the vitality of that. I'm going to use the word vitality. The vitality of this ellipsoid zone or this photoreceptor integrity line. Why am I focusing on that? The ellipsoid zone is mainly formed by mitochondria. So when you study an OCT, we know that there's blood flow in the inner retina. We know that there's blood flow here in the choriocapillaris. Basically, from right here where my arrow is, right about where the outer plexiform layer is, all the way down, this is all photoreceptor, and this is the externally limiting membrane, but this here is the ellipsoid zone, and these are the mitochondria, the powerhouse. And when you go to an anti-aging conference, they always talk about the mitochondria. The black line right above it, it's the myoid zone. The myoid zone is the endoplasmic reticulum and the Golgi apparatus, right? That's where all that protein synthesis occurs. So here's your energy of the photoreceptor. I geeked out when I saw this on OCT Connect, interpretation of OCT, OCTA, and I was looking at this. I said, okay, nothing really here blowing me away. Then I came down here to the RPE, and I see that this is like pink. I'm like, what's that? Why is that pink? Why is there? And I went down here, and it's the mitochondria of the RPE. The mitochondria are super, super important. And look where this immune reaction, this complement factor H, tying structure, function, immunology, I'm trying to tie this all together of how these diseases work. RPE, right down here, are the mitochondria, the photoreceptors of the mitochondria. The disease, we got to help this whole area out through an comprehensive antioxidant network. I am not poo-pooing lutein and zeaxanthin. I'm just saying we need to do more. And I'm hoping that this will convince you. When I went to this A4M meeting, you could see it's a huge meeting, lots of aisles. Man, I spent like 6 hours in here walking up and down. And again, the importance and the power of the mitochondria. Mitochondria, health is key to healthy aging. Mitochondria is all over the place. They're all coming up with different ways to help protect these mitochondria. We have ways that we can help protect the mitochondria. Here's some fun facts about the mitochondria. Mitochondria produce energy from organic matter. I think we all know that the powerhouse of the cell. They produce 90% of the energy in the body. Here's the bad news. Oh no, they also produce 90% of the free radicals. It's not a clean system. They become dysfunctional, and then they can create many clinical consequences. Let's check this out here real quick. The brain, every neuron in the brain has about 1 to 2 million mitochondria. The heart, 5,000 per cell. liver starts dropping. But look, the photoreceptor, when I was showing you that, the ellipsoid zone, one photoreceptor has 500 mitochondria per cell, and the RPE has more. And that's where the disease is. And it's all right here, reference. I'm not making these numbers up. And the mitochondria are very sensitive to reactive oxygen. That's your free radicals. The mitochondria need antioxidant support. All this is out there in the literature. We all know this. And that's why we want to do a comprehensive vitamin or supplement when we're treating a lot of these eye conditions. Here's another word that I learned, inflammaging. And what they do is they talk about the consequences of failing mitochondria due to the mitochondria reactive oxygen species, the free radicals that are damaging the mitochondria. And then they start producing these pro-inflammatory cytokines. Boy, doesn't this sound familiar, right? We have a lot of biologics that are out there that inhibit TNF alpha, right? That's what Humira and I believe Remicade, that's what they go after. Interleukin 6, that's another one that's big. That's when you talk about Actemra and GCA, interleukin 6. Here we go with all these cytokines, and you can see why the mitochondria are important. So mitochondria, and go back to now, where is the problem? We have these free radicals. They're produced just by our body, our mitochondria, and all our exposure. And this is why we're supposed to have a high score, whether it's a hand scanner, whether it's serum or an MPOD. That tells you that you have great antioxidant network. And when you have an angry free radical, it's going to balance itself out. You don't want it from a healthy cell. You want it from the antioxidants that you have. And this is how we can support our patients. And this is where a lot of this early diagnosis is going. I'm going to tell you, with all this early diagnosis, you better have a grasp on lifestyle, nutrition, the exercise, and recovery that's out there. Oxidative stress. I think we all know the free radicals, oxidative damage, oxidative stress. We've all seen this apple. Cut it in half. What's it exposed to? Oxygen. And it rusts and it dies. The same thing is what's happening to our body. I love to do this during a live audience. Here we go. Here's a whole bunch of free radicals. We have oxygen, we have peroxide. Should we have peroxide in our body? I'm going to pause for a second and ask, should we have peroxide in our body? And the answer is yes. You should have peroxide in the body. It's part of our immune system. But what happens if we get too many free radicals? We don't have enough antioxidants to balance them out. We start having too much peroxide, and now it starts becoming not part of the immune system and beneficial. It starts to damage us. So we use peroxide to clean contact lenses, right? Or hydrogen peroxide. If we get too much peroxide in our body, it starts creating cell damage. And that's why we need to have this balance. The body loves homeostasis. Here we are. Here's that aerobic respiration. This is that, the ATP being formed by those mitochondria. It's not a clean system. That's why it produces 90% of the free radicals. The other 10%, UV light, as you can see here, air pollution, smoking, metabolism, inflammation. That's where we quickly become out of balance because our food sources in America stink. We don't eat enough fruits and vegetables that are out there, and we quickly become tipped to the free radical side. Here's the one example. I get these sent to me all the time because people now know I lecture in this space. In orange of 1950, it takes 21 of today. Someone recently sent me something that said it takes 43 bowls of spinach. Here's what the antioxidants in the fruits and vegetables come from. When you plant them in the ground, if I plant them in Pennsylvania here, I don't have the best weather. If the plant survives, if it survives the weather, the hot, the cold, it's pulling the nutrients, the antioxidants in those plants, and we'll say carotenoids since we are familiar with it, the carotenoids in those plants are what protect it when we grow these things in such kind environments, warehouses, mass producing, they don't have a chance to get tough. Tough means the antioxidants in them. So that's why our food sources are not the best. I love when it's like in my area, I love like end of June, July, August, when the farmers markets open up. Man, I eat those fruits and vegetables because I know that they're not grown in greenhouses. They're grown here, they're weathered, they're tough and full of antioxidants. So think of it that way whenever you're looking at your fruits and vegetables. So your equalizer is supposed to be the rainbow, but sometimes the rainbow is not as bright as it should be. And I thought this was kind of funny. I was walking through a Marriott on a way to a lecture one time. And here I took a picture of this. I actually laughed out loud. And you could see this person, they ate the eggs. That's okay. I'm okay with that. Then they doused it all with this high corn fructose syrup. And it has tons of sugar in it. But what I laughed about was they left the fruits and vegetable, or they left the fruits behind, right? The pineapple and the cantaloupe. So you could see here kind of that old standard American diet, right? Standard American diet, sad diet. And that's why we see much chronic disease. And as I showed you how that graph kind of tears off that's out there. So when it comes to nutrition and antioxidants, we're familiar with a lot of these. We see here that, there are tocopherols, vitamin E, and then there's like 8 different versions, like alpha, gamma, beta, so on and so forth. Ascorbic acid, which is vitamin C, carotenoids. And these are the well-known ones in optometry for sure, lutein and zeaxanthin. And there are companies that are out there that make awesome lutein and zeaxanthin. But I hope you see my point here is that we need to be, of the alphabet of A to Z, we need to have more than just L and Z. We need the whole alphabet that's out there. And that antioxidant alphabet helps us neutralize those free radical, repair the oxidized membranes. It decreases the reaction oxygen species and neutralizes the reactive oxygen species that are out there. All right, polling question number 6. I need to take a break here. So the question to the audience is, and Jenna, if you can launch 6 for me, can our body manufacture these antioxidants? Vitamin A, C, E, carotenoids, polyphenols. We heard about resveratrol, quercetin. Can we manufacture them? Yes, no, or I'm not sure, and that's why I'm here. So Laura, I see your question is rolled in here. Since mitochondrial DNA is inherited through your mother, do you think that there seems to be a more genetic link to maternal history? I'm going to just off the top of my cuff, just say yes, that's out there. Mitochondrial DNA definitely comes, that history comes from the mother. So I got one here as this is rolling in. What genetic company do you use? I only know 2. I just got a call from Arctic to see if I could start using in the office and playing around with it. But the one that I showed you was Visible Genomics. What was the scan from the hand scanner color wheel? That's it's by Pharmanex. It's the hand scanner. There's a couple other scanners coming out, and I believe they're going to be reflectants. I got to do my due diligence on it, so I don't want to speak out of turn, but I believe reflectants can be influenced by hemoglobin and skin color, and that's why I kind of go down the road of Raman spectroscopy. So do your due diligence between reflectants and spectroscopy. They're not the same. All right, we can end that poll. I think we got a good amount of people rolling in. Jenna, you're being awesome. Thank you, back air. And you could see here, the majority, 65%, said they cannot be produced. That is the answer. 22% said our body can make them. And 13%, thanks for being honest. And that's why we're here. That's why we take education. And thank you, Dr. Wu, and the Wu U and the university for putting this on so that we all can be better for our patients. So here's the antioxidant network right here. We do have some endogenous where our body can make them. And you could see here, like, I don't know, glutathione. It's why it's important. And a lot of docs out there, a lot of naturopaths like to focus on glutathione, but our body can make it. Exogenous, A, C, E, K. I'm not going to read the whole list to you. You could see the polyphenols, the phenolic acids, the flavonoids, resveratrol. These cannot be made by our body. We have to eat them. So where's the problem lie? We don't have the best food sources. We don't eat the rainbow, and we quickly become a free radical body, now leading to chronic diseases that are out there. So when you do antioxidant support, you certainly get cell membrane support, immune support, oxidative stress. COVID taught us a lot about that immune support, and then that extracellular matrix and those cells talking to each other. Carotenoids, why do you hear so much about them? We see here, I'm glad that when Melanie was talking here, she was kind of focusing on, again, the blue light filtration, the glare. Absolutely, our macula needs to be with these to help, or our fovea, if we're going to say they're misnamed, our fovea, to help with that blue light and glare disability. And then this was a cardiologist that showed reversal of his own coronary artery disease. And how did he do it? He didn't do it through the stuff that he does to his patients. This person did it through flavonoids, increased nitric oxide, increased blood flow, and helped to cure his coronary artery disease. And this was by a cardiologist that did it that way rather than, bypassing or stenting. So carotenoids, here's some numbers that are out there to kind of help you to start thinking of more of a comprehensive approach. 600 or 700 in nature, whichever study you read. I went with 600 to this one. I go to some lectures, I hear 700. 50 are in our food chain, and 15 to 20 are detectable in our blood. Right. So there's a lot more carotenoids out there. Now, lutein and zeaxanthin, from my understanding, are only found in our body in the macula. So they're super, super important in our fovea. But again, back to that glare disability being that third lens. And I do believe they do give some added protection for macular degeneration, especially for those cones. But we need to do a little bit more and get beyond that layer of fiber of Henle. So, question here to the audience, Jenna, if you can do this one. Curious, do you measure carotenoids in your office? Do you do the hand scanner? Do you do an MPOD? Do you check serum? You can certainly do a serum test. And then based upon an MPOD, a biophotonic scanner, a serum test, then are you making a recommendation? Kind of curious here. All right, that looks pretty well caught up. One is, would you possible to get a copy of your lecture and handout? Absolutely. You can email me. I'll have my email up. I can burn this into a PDF where it's the full slides and send them to you. Where do you stand on eating the rainbow versus avoiding nightshade production? I'm not nightshade produce. I'm not sure what that is, Jeff. It'd be great to have it, but I believe you should eat as many of the rainbow as possible. Because we can't supplement ourselves out of a poor diet. But I'm a big believer, especially knowing the food chain. It's kind of funny. I just went to the store the other day. It's now April, and I can get a fresh apple. That apple was stored for about 6 months in a gas chamber. So, so it becomes a sugar bomb, certainly. So, all right. All right, we can end that poll. I think we got a good result. Thanks, Jenna. You're being awesome back there. Thanks, crew. And this is the key, right? Everyone talks nutrition, but who are measuring it? And we have a way that we can start doing that, right? That's why I like making supplement recommendations. Man, what a powerful 30-second scan in the office that I can now have a great conversation. And guess what? 70% of my patients come in on a supplement. And they think, man, watch this. I'm going to show Dr. Caldwell something. They put their hand on there. and and now I can have, it's like the lie detector of supplements. So really, really cool to be able to do this. Again, we don't really fit contact lenses without measuring prescription-based curve Ks. We don't really prescribe glaucoma drops. I think your pressure might be, I don't know, it might be up the way your nerve looks. I'm going to throw you on some drops. What I want you to do is start to get what's called point of care testing. We can do it now through fatty acids. We can do it now so we can help our patients out. And again, some of the literature, as we're seeing here, recent literature is pointing, saying that maybe us docs should be looking into measuring, and maybe it might become a part of the comprehensive exam. And if it does, now you have a lecture that you can reference to and how it got there. Significance of carotenoids. We talked about this a little bit earlier. High blood levels of carotenoid alpha may reduce the risk of dying from cardiovascular disease. And again, back to mortality, and we know about macular degeneration, and here's cancer. We didn't touch on cancer. Having a high carotenoid level really drives down that chance of getting cancer. Low levels of carotenoids, persistent HPV infections. Think about it. The immune system. And if you think about what happened in COVID, those who had that weren't oxidatively stressed, remember, the body needs the virus loves oxidatively stressed bodies because it can spread. It can't spread through a body, or not as easy. It can spread, I guess, but it doesn't spread as easy when a body is not under oxidative stress. That's out there. So that's what we're talking about. So remember, how big is the macula? This is how big the macula is. Right? Look how big the macula is, and those all important, macular pigments are here. So yes, if you want to kind of target that retina after putting down a foundation, music to my ears that's out there. I start seeing some of the questions that are rolling in here. I thought this was kind of funny. Alan Glazer asked me to hop on ODs on Facebook and kind of give some validity to his his ODs on Facebook. Here's someone talking about drusen, basically summing it down. Who monitored this, or what do you do? Maybe there's an epiretinal membrane. All these people said monitor. This person got creative and put a GIF in there, and I just caught it at the wrong time, but it was a monitor that was rotating. I think we could do more for this patient. So let me show you some oxidative stress. You see, when you see this drusen and you see this breakdown of this, which we can use at OCT, we're able to see oxidative stress. Here's the drusen, here's the immune reaction, here's the oxidative stress. I got a better one coming up right here. Look at your mitochondria line now as you go across. When you're starting to see it fade, that's this part of the apple. Right? You are seeing oxidative stress right here. This picture is what's happening. We're kind of in some areas this apple, and in some areas over here where it's dying and getting RPE scars, and you're getting this light, this coherent beams of light going down through. It should stop at the healthy RPE, and these beams are now going down through here. It's like cracks in the cloud. It's allowing those rays to get down through. That's telling you how diseased this RPE is. And we should have helped this patient out a long time ago, but we could still help this patient out. I would go with a huge comprehensive A to Z and hitting this patient hard to try and calm down that immune reaction. But what about this patient? It's controversial, right? What to do for these people. Let's go back and learn what Greg Jackson from Maculogics taught us. He created the big box, and then he created the little headset. Here we are down at the RPE. Here we are at Brooks membrane. And this is the way it should look, right? We have a healthy retina. We know that these drusen, this process starts a lot earlier. And what he was able to show through dark adaptation is that you start to get the cholesterol buildup at Brooks membrane. I'm going to go back. Look how healthy this looks. Here's the oxidative stress that's starting to occur. You have cholesterol. Remember, the mitochondria, this is all part of that tying structure, function, molecular all together. Here are the mitochondria down here at the bottom. Here's the oxidative stress. Here's the inside, the photoreceptors plugging in right here. The disease, the complement factor 3 mutations, the complement factor 5 mutations, the stress, all of this is happening, getting more stress, still no drusen, no drusen. Now we got the drusen, right? So now we have drusen occurring. Now remember, this is where the RPE are, the mitochondria of the RPE. Here are your nice, healthy, robust, really vitality of those mitochondria. And down here, remember the mitochondria. And when we do this, this is why they say dark adaptation can pick up macular degeneration 3 years early. So when you do dark adaptation, what do I do for the patients? When they're reduced, I put them on a comprehensive, because I want stuff that's going to help. Resveratrol, astaxanthin, curcumin, all that stuff that's out there, lutein, zeaxanthin that's out there to help fix this oxidatively stressed eye. Now, here's the Beckman classification. I was talking about this earlier when I said, remember that picture of those few drusen. Does this bother anyone when you look at this? Intermediate, advanced, this is where AREDs are for, and really that's about 3% of your patients. What about early AMD? And what about this? It says no AMD. No AMD, but yet there's drusen. No AMD, but yet there's drusen. Drives me crazy. It's like saying back in the day when we did digital, breast exams, feel for lumps. Now we have mammograms. And, I can't fill it, but we've picked something up on your mammogram. Well, you know what? The classification system says, well, you really can't fill it. That would have to get as big as intermediate or advanced. We are giving false sense. And it's not that I'm throwing this under the bus. This was a long time ago, but we still reference it. We can't be calling drusen no inflammation. No AMD. It drives me crazy. I saw this the other day when I was scrolling through Facebook, whatever the stuff that was for sale, this dress, it says never worn. Well, isn't she wearing it? I think she's wearing this dress, never worn. A little bit of concerning. I guess you shouldn't read everything you believe, everything you see. This is disease. This is inflammation. This is inflammation right here, right? Those drusen might be here. We're calling this no macular degeneration. It's macular degeneration. Do something for your patients. You don't have to see a double-blinded study that's out there, blah, 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 blah. It's common sense that's out there. It's inflammation. Do something for your patients and help them out. So this was my reply to this. Everyone put this kind of monitor. We were talking about, does this patient smoke? Why are we doing, zinc? Are we checking things out? What's their status? I would do a little bit more than just monitor for this patient. Now, we focused a lot on macular degeneration. How about these patients that come in and they don't have any diabetic retinopathy, but yet we use an OCTA because diabetes is a capillary disease. So we probably should look at the capillaries, and we see capillary dropout. Can we help these patients out? We can see that here's OCT angiography. We're not going to turn it into an OCT course, but you can see the dropout that starts to occur. And then maybe as the dropout occurs, we start seeing some of the B scan changes like right here. Now, like right here, we see the foveal avascular zone, but the B scan looks beautiful. There's diabetic retinopathy. What can we do to help these patients out? Can we do something? The answer is yes. Take the oxidative stress off of the eye, off of the body, off of the retina, right? We know we can help that out. We can help our patients that have oxidatively stressed eyes. And this is just showing off. You can see in glaucoma, the wedge defects and what's happening vascularly here in glaucoma. And here we are, Paul Chouse, who is, one of them, probably the smartest guy, the smartest optometrist in eye care. He's a patient with diabetes, vitrectomies, PRP, nothing. I'm not his eye doc. He's talked about it in his conferences. knows diabetes inside and out. He, Stuart Richard, Jeff Gerson, and Ray New here did a study and basically, look, diabetes, all these different stresses, hormones, there we go, hormones, dyslipidemia, but look what it all funnels down to. It all funnels down to oxidative stress. Two things are going to happen in their diagram: death or inflammation. And then that's what leads to diabetic retinopathy. Now, they kind of help put a formula together for I Promise, and that's their disclosures when they talk and so on and so forth. But look where they started going with this. They started looking at things that mitigate diabetic retinopathy, improve the retinal capillary fragility, reduce VEGF, naturally reducing VEGF. And you can see the laundry list. Look how it's starting to become comprehensive. And in their study, they found that doing something like a more comprehensive approach, reducing, can help in this, what was called the Diabetes Visual Function Supplement Study. So they're now starting to go a little bit more comprehensive. See the theme of where I'm going? Us allopathic docs, we started targeting how much vitamin C and vitamin E, because that's what we like to see. How do these individuals work? On the naturopathic side, they kind of look at everything kind of being synergistic and working together. So like resveratrol needs alpha lipoic acid, and alpha lipoic acid needs curcumin, and curcumin needs vitamin D, and all the vitamin D needs vitamin C and B, and it all works together. In pharmacology, when I take Advil and Tylenol together, we call that synergism. The pain, the analgesic effect. And on the natural side, it's the same thing. It's synergism with these antioxidants networking together and working together. So there's evidence all across. You can just search for it. Nutraceuticals help with diabetic retinopathy. This is from the ARI slide deck. Dr. David Epstein was targeting the trabecular meshwork for his Nutraceutical product. This is a slide deck right from that, that dinner program. Healthy trabecular meshwork, unhealthy. The pictures will tell you, I didn't change this slide. Look what they said, how we went from here to here. Oxidative stress, cellular damage. Do you think that my patients that come in, I try to convince them to at least go on some type of comprehensive oxidative, because that trabecular meshwork, we know it's an outflow. If we can keep that trabecular meshwork pliable and healthy, and those receptors healthy, we can pump out that some of that IOP and assist it, complement it. Integrative medicine is what we're talking about where I started off. Antioxidants can enhance ocular perfusion. Oral antioxidant supplementation may decrease vascular resistance. That can help in glaucoma. So here's an overlay. Here we go. Here's the nerve fiber layer. Here's the ganglion cells. Here's the ganglion cell complex. Here we are at the ganglion cell complex, and here's thinning that's occurring. Can we help those ganglion cells? Can we help those neurons that we can check with, like that ready valve, check those individual? Can we support and take that off? We absolutely can. We talk about the eye being the brain, right? So here's a ganglion cell. This is nothing more than a ganglion cell. Here it is referenced down here. This is where the picture come from. Ganglion cell of the brain. Here, or I'm sorry, a ganglion cell of the brain. And here we are here with a ganglion cell of the retina. And you can see the ganglion cell then turns into the nerve fiber layer, goes through the neuroretinal rim, goes back through the optic nerve. Once it goes through the optic nerve, goes through the chiasm, optic tract, and then we know that it synapses at the lateral geniculate body. That's the axon in glaucoma. When we say brain is eye, and Lisa Renzi Hammond said the eye is brain, this is why they say it. The eye is brain. So when we talk about axons, and right here, look, why does glaucoma? There's these different, what happens in IOP, prolapse cascade, toxins, here's calcium release, here's your TNF alpha. But down here, look, ischemia, mitochondria dysfunction, mitochondria in this neuron. So we want to support the mitochondria. Again, it's not the end all be all, but we can do things out there to help these patients. I thought this was pretty neat. And Julie Poteet, the president of Owens right now, kind of made a comment on there. Thanks for breaking this down in an easy way. Here, this is what this person is saying. What's the nutrition got to do with brain health? Okay, so look at this neuron. We have homocysteine. Remember, we referenced homocysteine. B9, B12, B6, riboflavin. That's for the homocysteine metabolism. How about blood flow, polyphenols and flavonoids? How about that cell membrane? There's going to be EPA, DHA in there, but vitamin C, vitamins, polyphenols. How about the nerve impulses? Again, DHA. See my point? You need to have a comprehensive network. Here's the brain, here's the eye. We need to be giving it a comprehensive network. So our AMD treatments, you could see here, we want to stop smoking. We want to do lifestyle changes. We talked about the AREDS formula here. Frequently asked questions is for intermediate and advanced. Now, I'm just going to skip this because I see we're getting close to our, I don't want to take advantage of our hour and 40 minutes. Now we're down to 9 minutes, so I'll skip that. But my polling question was, during the AREDS study, were patients allowed, you know what, we got time, launch this for us. For me, Jenna, launch poll 8 here for me. I'm curious. I want to see what happens. During the AREDS study, were they allowed to take multivitamins? Yes, no. And if it was yes, 10% took them, 50% took them, or 90% took them. This is polling question number 8. If you can launch that for me. If not, I'll try to. Thank you very much. I know I told you not to, and you probably stepped away. So during the AREDS 2 study, were they allowed to take any other vitamin? Yes, no. If so, 10% did. If so, 50% did. And if so, 90% did. Right? This is a study that's been out for 20 years. All right. How about if we end that poll? And we have the majority, 51% saying yes. We have 10%, 12% saying 10%. We have 31% saying 50%. And the smallest amount, 90%, was 6%. 22 people of the 358 that responded, 6% said 90% were allowed. All right. Well, let's go to the frequently asked questions. You can go Google it. Frequently asked questions, National Institutes of Health, the National Eye Institute. Can I take multivitamins if I'm on an AREDS 2 formula? Well, of course you can, because AREDS 2, 9 out of 10 participants took a multivitamin. Look, 6% of you, 22 of you were correct. 90% of the patients, 9 out of 10, took multivitamins. So when you recommend AREDS 2 for those 3% of the patient that have intermediate or advanced, are you recommending a multivitamin? Something to think about, because 9 out of 10 were taking it. Frequently asked questions, all you have to do is go and Google it. I just brought it to you. It's not controversial what to do with subclinical. I hear speakers all the time say, controversial flourishes. It's not controversial. It's inflammation. Take care of it. Put out the inflammation. Help the patient out. Give them some support. So you can measure macular pigment. We went through it. You can measure it through many devices in the office. You pointed out where I think the limitations are. See this disease? I showed it to you. Here is the layer of Henle right here, right? Please replace lutein and zeaxanthin. Use a formula that has it. My formula has it. Just go more comprehensive. That's out there. So the macular pigment, I showed you multiple times. It's right here. It's right here. You can get drusen disappear if you go at it at a high antioxidant report. All right. Do you recommend resveratrol and quercetin? I do. Let me show you. There's lots of studies. Oxidative medicine, cellular longevity. Here we are saying that resveratrol, quercetin, Stuart Richards' favor, quercetin, and if you combine them, they can have a synergistic effect. Here's the beauty of resveratrol. Resveratrol can be applied in anti-aging. Here's the mitochondria environment by regulating the levels of inflammation. Furthermore, it is a natural inhibitor of VEGF. So I use this for my patients with wet AMD. Make sure there's a formula with resveratrol. I make sure that the patients that have diabetic retinopathy are on a comprehensive formula that's out there. Thank you, Chris Putnam, for sending this to me. Look at lutein and zeaxanthin. They all have this OH group, OH, OH, OH. Quercetin, OH. resveratrol, OH, curcumin, OH. It's all about the OH. That's what goes and donates to help neutralize that singlet oxygen. That's why quercetin is huge, singlet oxygen quenching in macular degeneration. People say, show me the evidence. Thank you, Chris Putnam, for showing me the evidence. RPE, quercetin, neuroprotective, quercetin, anthocyanins, protection to the RPE, macular degeneration in the outer retina, curcumin, more literature search showing macular drusen volume regress with curcumin, resveratrol. The evidence is out there. I'm just trying to bring it to you that it helps our patients. And that's why I love this test in the office. It's a quick test. It's used in science. We've seen it. It's Raman spectroscopy, the biophotonic scanner. It has been shown that there is a correlation between macula, skin, and serum, a really easy way, and it's that phospholipid bilayer membrane. It was developed by the National Institutes of Health. It went to the University of Utah and then got turned into this small portable device that measures within 30 seconds. It's a really simple. Raman would turn over in his grave hearing me say, yellow and blue make green. But that's all it does. This very specific blue light of 478 hits a yellow carotenoid and bounces back a green light. This is spectroscopy. It's not the same as reflectance that's out there. Hundreds of studies have validated this over time. Here's Arvo again. We saw this, Paul Bernstein saying the hand scanner can match the macula and it's better than the objective M-Pod that's out there. And when you score low, this is what your cell membranes look like. And when you score high, this is what your cell membranes look like. This is a cell membrane. This is a cell that is ready. It's not under oxidative stress and it's protected. So are you taking supplements and how do you know they're working? I'm going to wrap this up here. I have about 3 minutes. I'm going to go through a few slides. Here's a case history. This is how I use it in the office. 53-year-old man comes in. Hey, my dad has 43 injections. What can I do? This is not good. He's already kind of got a stress on his body. He's got a borderline hemoglobin A1C. Vision's 20/20, retina's clear, OCT normal, passes dark adaptation. I could do genetic testing, but I said, put your hand on here. He scores 26,000. Here's an A plus, A, B, C, D. They understand, hey, you just scored a D. Now, you want to stack the deck in your favor? Yes, I do. All right, let's go on a comprehensive formula. Look, I don't hate lutein. Now, people will say, look, it's at a 10 to, it's not at a 10 to 2 ratio. I don't need it to be a 10 to 2 ratio when I have the other supporting characters. When I have things like alpha lipoic acid and resveratrol and grapeseed extract and quercetin and all the other supplements, that's called synergism. I don't need a 10 to 2 ratio. If I do an isolate, I need a 10 to 2 ratio. I don't need a 10 to 2 ratio. Zeaxanthin is in here. I got lutein plus all the other cast to help me out. He wanted to do something else, so I placed him on another supplement that has an epigenetics to it. And he came back. Let's go and see. I don't really do this, but he was really nervous. He came back. There was the 15th. He came back on the 27th, and he went from 26 to 33. What I failed to mention, this is a 60-day scan. When you measure the palm, the patients will come in and they'll be like, oh, I'm going to score terrible. I was over the weekend. I did this. I did that. I said, relax. It's the last 60 days. It's like a hemoglobin A1C of your fruits and vegetable. So he scored low. He came back. He went to 33. And I said, get back. Skin turns over every 60 days. You're not allowed to come back for a month. And he did. And we all started to exhale because you could see he's at 47. And now today he sits in the blue. We have stacked the deck in his favor. He is super happy. So when you start doing things like that, I've got more of an N of 3, but I got N of 3 in this slide deck. You could start reversing drusen. You can make these drusen disappear. It doesn't happen to everyone. You could start getting things like this. Since this is longer than we have gone before, well, no kidding. I'm taking some oxidative stress on, doing some things that inhibit VEGF naturally, so they don't have to keep getting the injection. I've asked them to keep a close watch on his vision and contact us right away if anything is worsening. Look at that. That's pretty awesome. We're going to see him again in 11 to 12 weeks. These are people getting VEGF injections. I see this quite frequently. I screen everyone in the office because kids have terrible diets. They score the lowest. We get the patients, we get the parents involved, and there's lots of out there on antioxidants and carotenoids. This is my score recently, again, 63. I've started to introduce some exercise into my office. I want to say to my lifestyle, thank you for the opportunity. Do it for yourself, do it for your family, do it for your patients, do it for your staff. So, Dr. Wu, I'd like to thank you for allowing me to be here. I didn't change this, but thank you for allowing me doing ocular nutrition, time, function, structure, and molecular together.